Thank you so much for inviting me to present. What I'm going to present here today is an INBRE pilot 2024-2025 that we finished a bit early, actually. We finished in January. So I'm thrilled to present the project, including the results. We've actually had it accepted to a couple of meetings, GATE meetings and cerebral palsy meetings, and are in preparation of a manuscript soon to be submitted. So the project is called Biomechanical and Functional Outcomes of High and Low Burden Multilevel Surgery in Youth with Cerebral Palsy, conducted at Nemours Children's Hospital here in Wilmington, Delaware. Oh, my slide is not advancing. Nothing to disclose. So the project is about multi-level surgery in youth with CP, and the multi-level is a very important part. So pediatric orthopedic surgeons aim to address all of a child's deformities in one surgical setting. So deformities at multiple levels: pelvis, hip, thigh, knee, calf, foot, ankle, and the surgical procedures that can be performed in that multi-level surgery event can be on muscle to reduce contractures and improve range of motion, or they can be on bones, osteotomies or fusions. And the surgery on muscles tends to be at a lower physiologic burden. Muscles heal more quickly. It's a little better tolerated, whereas bony procedures take longer to heal, are more painful, and may extend recovery. So the decision to do surgery and the specific decision about the procedures is based on a gait analysis. All the data here comes from the gait analysis lab at Nemours, where we're collecting kinematics, kinetics, EMG information on a child's gait pattern. And then my background is physical therapy. So in addition to that instrumented gait analysis data, we're also collecting data on gross motor function, how independent the child is, how they carry out their activities of daily living, and how they do kind of in the real world walking activity. So the aim of this work was to determine the impact of surgical burden, as well as the contribution of some other patient factors to the change in gait pattern or biomechanics, and the change in mobility function after multi-level surgery in ambulatory children with CP. So as I just alluded to, not all surgeries are created equal, and what we do here at the Nemours CP program is classify the surgery as a low burden surgery, which would be only one osteotomy or even no osteotomies and soft tissue surgery only, or high burden surgery, which would be 2 osteotomies or more. A child can have, it's not uncommon for up to 5 or 6 osteotomies in one surgical event. So this is a IRB approved through Nemours retrospective cohort. We included children with a diagnosis of CP or a CP-like condition at gross motor function classification levels 1, 2, and 3, which are the ambulatory functional levels in cerebral palsy. And then the other main inclusion was the child had to have a pre-op and a post-op instrumented gait analysis. Our primary outcomes for biomechanics were a gait deviation index, is a summarized kinematic index, so taking into account lower extremity kinematics, pelvis, hip, knee, ankle, foot. I think there's 15 kinematic factors in this summarized index. And then for function, we looked at the gross motor function measure, which is specifically designed for youth with CP. We looked at gait speed, a parent report of daily function, and this community-based walking activity. And as I've said, our primary interest was looking at the difference in outcome of high versus low burden surgery. And then additionally, we looked at factors of age, GMFCS level, the CP pattern of involvement, meaning bilaterally involved, unilaterally involved, the baseline measure that we were interested in, so the GDI, the GMFM, walking speed, gender, and history of prior surgery. So our clinical cohort included 178 episodes of low burden surgery, 139 episodes of high burden surgery. The patients in the low burden group tended to be a little higher functioning. So you see in these pie charts, if you particularly draw your attention to the GMFCS level 3 piece of the pie, the yellow piece, there are more of those children in the high burden group, and those are the children who need a device when walking. They may even need a wheelchair for part of their mobility. So the high burden group was a little bit lower functioning. And the high burden group was also a little bit older, 13.6 years versus 11.4 in the low burden group. And then, of course, the number of surgical events the number of surgical procedures in a certain event were much higher in the high burden group, hence the high burden. So here are some results. So first, I'll show you our biomechanical outcomes. The gait deviation index improved in both the low burden and the high burden group. The scale is 0 to 100, with 100 being what you would expect of it, for a normal gait. So both groups improved, and then in our regression analysis, we saw that the baseline GDI was, as an individual factor, significant, and GMFCS level was significant in that the children at level 2 didn't do quite as well as the children at level 1. The children at level 3 did not do as well as the children at level 1 in terms of improved GDI. So those are the biomechanical results, and then these are the functional outcomes. So first of all, GMFMD, gross motor function measure dimension D, the low burden group improved in that score, and the high burden group had no change. In terms of gait speed, the low burden group improved in walking speed, whereas the high burden group actually got a little bit slower post-op. The parent report measure we used improved in both groups, and our measure of walking activity in the community and ankle-worn walking device, we saw no statistically significant change in either group. And then our regression analysis showed that the baseline value of each of the measures. So here, this table is much busier. The regression model, there are actually 4 regression models here, one for GMFMD, one for gait velocity, one for PODSI, one for walking activity. And as a significant factor, the baseline value of each of those measures was significant. So lower GMFM, gait velocity, PODSI, or walking activity was associated with more gain. Similar to the biomechanical outcomes for GMFMD and gait velocity, the gross motor classification level was a significant factor. And then our main interest, the surgical burden, was a significant factor for GMFMD outcome and gait velocity outcome, in that the lower burden tended to make more gains than the higher burden. So the key takeaways here are that biomechanics improved after both low and high burden surgery. In terms of mobility function, though, you can expect more gains after low burden multi-level surgery, and we actually saw this decline in gait velocity after high burden surgery. Clinically, the way that this informs our practice here at the hospital is that the expectation for children and families, we may be able to better manage for that high burden group after surgery. And then as a research takeaway, my interest is now investigating additional patient and environmental factors associated with better functional recovery. So as I said at the beginning, my background is physical therapy, so certainly I want to look at that as an environmental factor. Just a couple references there, and an acknowledgement to my collaborators at Nemours and the institutional support here, and then of course the Delaware INBRE funding mechanism.